Hey John, how are you doing? Good
Morning,
morning.
everyone.
I would like to introduce the people here, and you will see throughout the 2 days, you will see a number of people taking their not first steps, but second or third steps in the world of ESD and perm. Some of them their first steps in the world of submucosal endoscopy. And I think that you will also see some demonstration cases. We've taken on board that feedback from before that actually what you want to see is not just people learning, but you also want to see people who can do the procedure and who can talk about it. And so this is something that we will do. And so we probably have 8 cases throughout the 2 days. And 2 of them will be demonstration cases. The other 6 will be learning cases. And of course, that doesn't mean that if the learning is too difficult or doesn't go well, that you won't end up being a demonstration case. So I think that, to be honest, you have the best of the world here. Okay, John, why don't you introduce your so John will co-faculty with me. Also, we'll have Locker will join at a certain point. Zoma from Roeselare, and we also have Linda Bells on the virtual to talk to us about their expertise in these procedures. John, why don't you start by, I think people know my background in therapeutic endoscopy, so why don't you introduce yours in terms of ESD and perm, so we can then introduce the group.
Okay, thank you, David. I mean, my journey was very interesting. I'm a lot older than David and really had a well-established tertiary practice in piecemeal EMR and very large complex polypectomy. And to be honest, I grew up with Michael Burke and those were my contemporaries. And I lived through an era where there's nothing I couldn't really do there's nothing I couldn't do with a snare to remove a lesion. And the indications for ESD that time were quite small. It became very clear to me through going on courses and attending meetings and demonstrations that ESD was around and it was finding a niche. It was a different skill. And I wasn't sure I was the right person to do that. But by default, being the therapeutic endoscopist in this area, I decided I'd have to acquire the skills. That was catalyzed probably in two events. Firstly, I met Michael Burke as well, who's well known to David and some of the guys in Ghent. And suddenly he was doing ESD, having been a massive proponent of EMR. And I thought, that's interesting. And I had a conversation and asked him how he learned. And then I went away and thought, okay, that's something I probably now need to acquire. And I spent a lot of time watching experts at the very top. So the guys from Japan, I was very fortunate to share a platform with. I watched them intently. I listened to how they did it. It's very interesting. They were very good at doing it, but there was very little teaching went on. So it was mainly observation. And then I did a series of animal models, and I probably was training for best part of 3 years, really, before I went on any humans, intermittently, albeit. The second event was David came back from Australia, having been trained in third space endoscopy or ESD, and he enabled me really to start operating on patients because I think you need someone there with you who's got the experience and the knowledge to support you through that process. And there's a huge difference between ESD in patients and ESD on animal models or other sort of models. In some respects, they're a little bit easier, but in a lot of respects, it's more challenging because of the vascular problem, and things get very bloody very quickly in patients if you're not controlling that environment. And obviously, the consequences for patients are huge. So the stakes are very, very high, and understanding concepts is an interesting one. So things with a snare give you a start, and I think there are some key skills you need, and we'll almost certainly go through these. But unless you've got a very good understanding of colonic anatomy, the layers of the colon, mucosal planes, and then the lesions themselves, so you know which ones are going to be suitable and good for ESD. You know when they're going to be challenges. You have to have a plan B. So you need a strategy. You need a plan B strategy if that doesn't work. and you need to be able to deal with complications, in short. And to ensure all that comes together, your tip control has to be exquisite. So going through the stages of learning how to do EMR was very important for me. And I would say now, over the last, I don't know, 5-7 years, something like that, my practice has shifted. So I almost do exclusively ESD. And it's mainly colonic ESD. And I share the rectal space with my colorectal surgeons. I'm sure we'll come on to that. Anything outside the rectum obviously comes to myself. I do very few upper GI ESDs. I do them, but my relationship with my upper GI surgeons is probably not ideal here. So I tend to get sent the difficult ones. And that's, again, it's a different environment for me because I am doing ESD without propofol here. Only one list a month do I have a propofol option. And upper GI obviously definitely needs propofol. Lower GI, there are pros and cons to having propofol or not, but most of my lower GI is with just sedation. I don't want to take up too much of your time, but my other thing I do a lot is I teach and I look and watch, and I've currently got I'm training 3 people here to do ESD at the moment. And I would say it's only within the last year or so that I've been really comfortable to sit down and allow them to do the ESD. And I haven't become anxious about them having the knife and me not having the knife. And that has taken a long time to get to that position. And to do that, I think you have to have confidence in what they're doing and the individual. But I think you have to be able to teach them in a way that they understand what they're doing and the risks associated with this. And to help try and support this course today, I've tried to dissect how I teach, what I talk about, and I'll hopefully impart and share that some of you as the course evolves. Yeah. Poem, I do very little poem, largely because of, as I say, I'm mainly in the lower GI arena. Interestingly for me, for poem, what would I say about poem? It's a good thing to do, I think, because everything's in a straight line. The risks can be high because you're upper GI, and I think the patient management post-poem is, I think, very important. So your relationship with your upper GI surgeon and the post-operative management for upper GI is, I think, probably a little bit more critical than, believe it or not, lower GI, which is, on the whole, if it's safe and it's well done and it's closed, it's a day case. Upper GI ESD is rarely a day case unless it's really something simple in the stomach.
I think that's a whole lot of information, and it should be interesting to you guys what's just been said, because John is started from a very different place to all of you. He started from a position of being excellent at EMR, being a referral endoscopist, getting referrals from large, huge population in the UK for chronic EMR when I met him, and it's a different thing, but it's based on the same core principles of observation first. And you heard what he said here. He said he observed for 3 years. Now, of course, if you're doing a fellowship, you can supercharge that time, right? Because you're observing much more. And then if you have a job and your job is, meaning that you can only do it once a week or every 2 weeks. So this is a different experience. But as you'll know, in a fellowship, you're not doing it every day, right? This is just not the case. It's not the real world. Whatever fellowship that you do, it will be every day. So you need to find another outlet for that. And I think some of these things will be very useful to us as we go through discussing. So thank you, John. Let's introduce the group who will be doing the ESD, and then we'll introduce the rest of the people. So we have got in the front row, you can see them here. You've got Samna to my right, to my further right, Andrea, and to my further right, Mitian. These will be the 3 people doing procedures predominantly throughout the next 2 days. And so I'll get them to introduce themselves so you know, as you're watching, what sort of level they're at. And maybe actually they are at relatively similar levels. I think it's probably fair to say. So this course is firmly pitched at people who are taking their first steps, and these guys are not taking their first steps. They're for sure doing a fellowship, and so this is the reason why they're here and why they're able to participate. But I do think that they can give you a very interesting insight into the difficulties that you might face as somebody who's starting out in these procedures. So why don't we start with you, Sander? Welcome. Please, could you just say a little bit about your experience in ESD up until now? Let's fix on ESD. We can do submucosal tomorrow, so just ESD, and what you want to get out of this course.
So my name is Sander. I'm a consultant gastroenterologist and a second-year fellow of David, PhD student supervisor of David. And I'm one of those guys who's taking the second or third steps in the ESD. I've previously done like a few circumferential incisions, only parts of procedures. Yeah, I fully agree with what John said. Observation is very important. Animal models, the access to animal models here is maybe less than in other centers. But indeed, like you said, David, if you're doing a fellowship with someone who's really experienced, the observation is, I think, replacing a lot of the animal models because you can do parts of.
I think it's also fair to say that you, in particular, I think, have done a lot of EMR. And so what John said about, I think that you're very good at EMR, and therefore you're at the level where John said that that he was when he started. And so I do think that you shouldn't undersell that part in terms of animal models, okay, but what do you need? And I think we have to say the animal model thing. I think it's important that you at least try it. But if you have the ingredients that are required for ESD, and what are they? A good knowledge of the, as John said, colonic anatomy, a good knowledge of how to do polypectomy and tip control. This is the key thing, right? And you have that, then I think that that's where we're going. Okay, and so you said that, but how much ESD have you done?
Like I said, a few parts of procedures, especially antrum, like the safe areas, antrum, distal rectum, and only like you did the majority, and in the part where you were like, okay, situation is controlled, let's undergo a bit of dissection, a bit of putting on traction or discussing traction, discussing other ways of making it more easy, more difficult, and especially like when you're doing stuff, just the conversation, I want to do that. Why do you think I would do that? That's maybe even more important, and that's also what I wanted to get out of this course. Like that is my opinion, and that was your opinion, and we discussed it. Why mine was wrong, or mine could work, or yours was better or worse, and then also the outcome. Like, okay, I suggested this, we did that, this happened. Why did that happen? But that's only two opinions, and that's what I think is very valuable in these courses and also these discussions afterwards. Is that was my view, that was your view, but Andrea has another view. Yeah, has another view. Oh, that's interesting.
I think that's absolutely right. So I think we very rarely, as doctors, and we in our environment, in our group, are very lucky that we're always observing each other's practice and always making each other better. But for people watching, most people operate in isolation. That is, that they are there with a nurse, and normally the relationship is the doctor says what happens, and that's what happens. So I think that this gives people a real opportunity to observe our conversations. Like, we are never having conversations to try and make people feel bad. We're never having conversations just because I want to say something negative about someone. No. Only conversations we have are, we could have done this, we could have done that. There's no right way. Often there is only a way that maybe you could have done it quicker, maybe you could have done it more efficiently, maybe you could have done something different and it was important to do it different because of X, Y, and Z reason, maybe an invasive focus where you need to go deeper, for example. But it is absolutely not the case that we have the right way. We certainly have a way, and we discuss it a lot. John as well, because he's part of the group. Lynn as well, she's part of the group. Lotka as well, she's part of the group. But what we are saying should just be for you very interesting, because we talk about our practice with each other, and we communicate with each other what is good, what is bad, and no one has any issues in this group about having their practice examined by others.
So good morning all, I'm Andrea, I'm from Italy, I'm a fellow here in Ghent, first year in interventional endoscopy. Well, my journey started with in learning submucosal endoscopy started with observation, and I was, I think, incredibly lucky to have experiences that changed completely my view and also broadened my horizon. So I've been in Amsterdam in 2022, so a large volume center doing ESD, third space endoscopy as well. So I started really to study more and to understand much more of submucosal endoscopy based on that experience. Then I also visited a center in the UK, Cambridge, doing also some courses and animal model. And I think now I'm here, and as David said, from the point where I came here, my understanding rocketed very quickly, because I'm exposed to an incredible number of procedures, and I study a lot. I watched a lot of videos, both in GIEQs and other resources, and I think that this is key, because you're understanding both of the technical aspects, but especially also the pathology. I think the pathology, understanding the pathology and what you're doing and what you're looking for, this is key.
So I'm also a Belgian fellow here in Ghent, PhD student. I think I can echo what both my colleagues have said, that observation is, I think, key. We observe a lot from other procedures, and we are always keen to try to do some parts of the procedure, but observing, decision-making, how would I do it? And then checking how the person that is on the scope is doing it is something that we learn a lot from, I think. Observation 1, lesion assessment is something that we spend a lot of time on to decide is what technique to use, because the technical aspect of doing a procedure is one thing, but knowing when to do it, when not to do it. So also the decision making, I think, is very important if you're doing these types of procedures. And as Andrea said, that's something that you can learn. You don't have to do that bedside all the time. You can learn a lot from virtual. As far as my experience goes, I've done a lot of EMR before. The year before I came here, I did a lot of EMR. And here I've done some ESD, especially also some parts of ESD, and then recently a ESD from start to finish, but rectal ones, and not too big, so it was not the most difficult one, but it was a big step. But also still at the beginning of the journey.
What do you hope to get out of the course today, Christian?
Well, one, to get also a different view of other people, some of the hands-on teaching, I think is important. Like, as I said, decision making, we do a lot, we learn a lot, but sometimes you have to hold the scope to be able to see what you can or can't do, or what you're doing wrong.
And how, with a more limited skill set, you can decide what you should do, what you shouldn't do, how far you can go.